Hi, everyone. It's getting to that point where the weather's getting nicer and restrictions are being lifted, and you're probably ready to get out there and just live your life. But one thing you don't want to do is let pain hold you back. And I know probably a lot of you have been letting that happen for quite a long time now. Today, we are going to talk about getting your knees and your hips back in shape. We are going to hear from orthopedic surgeon Paul Telehowski, and we're also going to tell you how the Center for Joint Replacement at Hurley is excellent, above the board. We are the only center for joint replacement in our area and one of the top ones in the country. So we're really the great place to go if you want to start taking those steps to improve your knee and hip health. As we talked to Paul Telehowski, we're going to be taking your questions live. And so if you want to text me, you can at 248-935-2562. You can send me your questions and I'll get them over to him for him to answer right here for you. You can also go on Facebook or YouTube and put those questions in the comments, and we'll take care of it from there. So Dr. Telehowski is a board-certified orthopedic surgeon with close to 20 years experience in knee and hip replacements. He's local. He was born in the Detroit area and went to U of M undergrad and medical school at Wayne State. He even did his residency here locally in mid-Michigan. He has some great information for you. So, hey, let's get started. Dr. Telehowski.
Thank you for joining us today. My name is Paul Telehowski. We're going to be talking today about the latest information regarding hip and knee replacement. I'd like to thank Hurley Medical Center for providing me the opportunity to speak to everyone. I think they're doing a great job at Hurley taking care of their patients. We've been through a rough time with all the COVID issues. I'm happy to say we feel very comfortable working here at Hurley, taking care of patients. Our environment is safe. We feel comfortable bringing our patients here. So I give them a lot of credit for taking care of that, taking care of our patients, and also providing me the opportunity to talk to everyone today. To give a little overview of the presentation today, we're going to talk a little bit about what exactly arthritis is. We're going to talk about some of the more conservative treatment options related to treating arthritis. Later on in the talk, we'll get into some of the surgical options that are available in treating patients that have unrelenting hip and knee pain. We'll talk a little bit about the surgery itself, a little bit about what goes on before and after the surgery, some of the recovery involved. There'll be time at the end for obviously questions and answers. And during the portion regarding knee replacement, I will talk a little bit about our newest technology, the Rosa knee replacement. Starting off with arthritis. Arthritis is one of the most debilitating diseases we see throughout the entire population. Over 30 million adults are affected by it. It really occurs when the cushion or cartilage within the joint wears out. It leads to pain, stiffness, and swelling within the joint. I think there's a big misunderstanding out there. A lot of people assume arthritis is something that grows in them, but I tell my patients, in fact, it's really not that. It's really more of a lack of the cartilage or a wearing out, somewhat like happens to the tires on your car after many, many miles. Some of the risk factors for developing arthritis can include injury, overuse, sometimes age, gender, obesity or weight, and our genetics. There's different forms of arthritis, the most common being osteoarthritis, the simple wear and tear form. There's also some inflammatory conditions such as rheumatoid arthritis that can affect multiple joints at once. Arthritis also can occur in any joint in the body. We see it commonly in the weight-bearing joints, the hip and knee, although some patients have shoulder, elbow, and ankle arthritis. When patients come see me, most of their symptoms involve pain. Some will report either stiff or swollen joints. They report symptoms to usually increase after activity or during activity. They'll report sometimes weakness in their legs or giving way. This is especially common when patients have bad knee arthritis. Many patients will report problems with their gait. During our exam, what we will see is usually a limited range of motion of the involved joint, grinding within the joint, or signs of injury to the tendons and ligaments that involve that joint. We will commonly take x-rays in our office. This is one of the most accurate tests we have for detecting arthritis. Occasionally, we may order MRIs to get a better look at some of the structures inside of the knees. Some patients may also be required to get blood testing if there's a concern, for example, for rheumatoid arthritis. Here's a couple pictures representing these conditions. On the left side, on the top, is more of an artist's rendering of what we see with hip arthritis, where on the far left in the upper corner, there's a normal hip, and next to that, a right hip, more diseased hip where the cartilage has worn. These are seen below that with X-ray pictures showing what on the far right, a normal looking hip joint, and right next to it a diseased hip joint where the cartilage has been worn away and the patient has the classic presentation of the bone-on-bone problem. Similarly, on the right side is a schematic of a knee showing a more normal looking healthy knee, and then an artist's rendition of the more worn cartilage. And likewise then underneath those, the more normal appearing X-ray with good space between the bones, and then on the far right, a pattern of bone-on-bone arthritis that is so commonly seen in patients. So early treatment in arthritis typically involves non-surgical treatment. We will almost always recommend an increase in people's physical activity to their tolerance. We encourage them to maintain a walking program, perhaps a stationary biking program, pool therapy, things that are more low impact and tolerable to the joint that is starting to wear out. This helps keep their muscle strength and their range of motion. We can also add physical therapy in some cases to add to this. Some patients' weight loss can play a big role in relieving some of their knee pain. These are weight-bearing joints, and obviously heavier patients may experiencing more weight in their knees and hips when they start to wear out. And so weight loss becomes a crucial factor in some patients in helping to control their symptoms. We can always add medications. Most patients, by the time they see me, have been on some of these, whether they be over-the-counter, Tylenol, Motrin type medications. We have prescription medications we can sometimes try, steroid, and sometimes disease-modifying agents can be utilized in patients that have rheumatoid arthritis. That's commonly done with the aid of our rheumatology colleagues. In our practice, we do perform quite a few injections for patients. This helps them control their pain, allows them to be more active. We will either use steroid injections or sometimes a product we call viscosupplementation. A common term out there is called the chicken shots. These are kind of like a gel or a lubricant shot that are put into people's knees. These can provide patients with good pain relief, allow them to stay functional. They are repeatable sometimes over time. And so managing people in this respect can go a long way at keeping them active. There are, however, times where those treatments don't always solve the problem for patients. Some patients may continue to complain of loss of function or pain. And in those times, surgery may be indicated for those patients. So I always get asked, is a knee replacement right for me? This is a common question patients ask me when they come in. My answer to them in most instances is that if their pain is severe enough that's limiting their activities every day, they're finding that they're not able to perform activities they enjoy or want to do, and they're living with pain both with rest and activity, it may very well be time to think about knee replacement. And certainly this is a point that a lot of patients get to, and the decision is then made to proceed forward with potentially a knee replacement. After we do a knee replacement, the good news is we can tell our patients that yes, they will be able to do walking, golfing, swimming, activities that they enjoy, including hiking, and even some patients low impact sports, golfing, maybe doubles tennis. We have a lot of patients that can get back to that stuff. That's quite rewarding to see after patients have a knee replacement. A lot of patients have given up those activities, and then after they get this procedure done, they're able to get back at those things that they enjoy. Most patients who have a knee replacement perhaps won't get back to running or jogging, but in most instances, since patients have given that up for a while now because of their bad knee, we don't typically see patients necessarily wanting to get back at that. And usually the high impact sports are a little bit discouraged after knee replacement, just because we don't want excessive damage to occur to the replacement itself. Currently at Hurley, we've been using the new Rosa knee system from Zimmer Biomet. We've had this product now for about 8 months. We have done quite a number of these knee replacements utilizing this system. I'm super excited about it. It's been great technology we've been able to bring into the area. We are the only hospital in this area utilizing the Rosa system. It is a device we can use in the operating room. You see a couple pictures of it there. It's a two-part system. One is a camera, one is a robotic arm. It helps us align and position the components when we do the surgery. The camera allows us to take measurements that really are a lot more accurate than I believe we were able to do in the past. And based on those measurements, the robotic arm then helps place this knee into patients more accurately and more precisely. We can actually plan the surgery before any of the cuts on the bone are ever made, and therefore we're not having to go backwards and potentially recut or change our plan after we've already committed to it. This system allows us to pre-plan the surgery before anything is ever done. And then once we have an acceptable plan that fits the patient appropriately, we can execute it utilizing this machine. It's been wonderful technology. My patients that have been through it now, I think we're seeing nice recoveries from these. I think by putting it in patients, we can get it to fit better. We can get it to fit the knee better. With that fit being better, I think overall patients feel better with the knee replacement. And in the end, the beautiful thing about it is I think patients recover their function very well. And that's what we've always been after when doing knee replacements, is to get a good fit so that it feels right to the patient, so that ultimately their function is excellent. I cannot thank Hurley enough for putting the program together for us and obtaining the technology to be able to use this for our patients here in the Flint area. So I really encourage patients to come in, sit down and talk about this as an option. We really have found it to be of great success. Going on a little bit further, I also do hip replacements. Patients ask me, is it right for them? When is the right time? Hip arthritis, certainly just like knee arthritis, affects people's activities. Continuous pain, night pain, it wakes them up at night. And so patients, once they get to this point, hip replacements can be an extremely successful procedure. I really enjoy doing hip replacements for patients in addition to knees, because we see with hip replacements, patients tend to recover quickly. They tend to get back up moving. They report excellent pain relief, usually very quickly after the surgery. And they're quite pleased with it very quickly on. Hip replacements don't particularly, in general, require as much physical therapy after the surgery as maybe a knee replacement does. And so patients who undergo these that have very bad hips seem to respond very, very well to them. And again, after a hip replacement, we allow patients to get back to their usual activities, whether it be walking, swimming, hiking, playing low-impact sports, exercising. These are goals that patients certainly can meet after a hip replacement itself. When patients are set up for a joint replacement through my office, there's some very simple things that may be done ahead of time. They may include a little bit of blood tests, review of medications. We do ask our patients to have any dental procedures done before their joint replacement. We don't want any type of dental work for about 3 months being done after a replacement, as it's a risk for possible infection. There may be a little bit of home planning needed. For example, if a patient has an upstairs bedroom, they may need a week or two of moving themselves downstairs. It's not that patients can't climb stairs right after surgery. They certainly can, but sometimes a small change around the house can make the recovery slightly easier. We at our office have a dedicated joint replacement class that we ask our patients to attend. My patients will meet with our therapist through Ortho Michigan one time before the surgery happens. Our therapist will go through the entire program start to finish. They do usually a home evaluation for patients where they will get any equipment that may be needed to just make the environment slightly safer for those first couple weeks after the surgery. Some of those things might include a raised toilet seat, a shower chair. Most patients don't need a lot of equipment, but small little things for the first couple weeks can make things go much smoother for patients. The day of the procedure, we bring patients in the morning. Our anesthesiology colleagues will see the patients. We do provide for knee replacements a block before the surgery. Patients will get a small injection in their inner thigh done under ultrasound guidance. This is very successful at relieving some of the immediate postoperative symptoms as it numbs the knee up very well. During surgery, once I put the knee replacement in, my patients will get injections into the knee before we close the incision. Between this and the block, most patients have very good pain relief for at least the first 24 hours after their knee replacement. It's a nice thing because as soon as we're done with the surgery, patients will spend about 2 hours in the recovery room waking up from their anesthesia. But because their knee is fairly numb, they're able to go upstairs to our joint replacement floor. We get them up, we get them walking, we get them moving. And so my patients, I will tell them 2 to 3 hours after the surgery, they will be walking on their new knee or their new hip. So we do like to get patients moving very quickly after the surgery. We have a few medications that they'll be put on. We don't use anything real strong. We want our patients awake, alert, being able to tolerate therapy. They can eat after the surgery. Most times patients will get therapy the afternoon after the surgery. They will spend the night, and then the next morning they will be up again with therapy participating. Most patients will work on stairs because patients have those at home. We need them to be able to accomplish that to go home. And the vast majority of patients pass therapy post-operative day 1 and are able to go home. In my office then, the follow-ups are usually at a 2-week, 6-week, and 3-month mark. So there's only about 3 visits after the surgery. The big portion of the recovery after knee replacement, patients will be required to usually attend physical therapy. It's mostly a 3-time-a-week program, day on, day off. where they're working with therapy, helping to move their knee. As far as hip replacements go, patients may require a small amount of therapy. Usually it's a bit quicker than knee replacements. They may only have to go twice a week, or sometimes even just once a week for just a little bit of monitoring and a change in their exercise programs. And so I look forward to any questions anyone may have. I look forward to seeing you in my office. And I again thank Hurley for the opportunity for me to sit down and talk with you today.
And the questions are coming in pretty fast and furious. So I want you to know, if you need to ask a question, you can text me at 248-935-2562 or go to Facebook or YouTube and post your questions there. Dr. Telehowski, we're getting multiple questions about how long a knee replacement will last.
Yeah, it's a great question. Something I probably answer several times every day in my office. I will tell patients there's no set standard necessarily for how long a knee replacement can last. But with the current technology we have now, I very much think 20 to 25 years can be a number that can be discussed with patients. It does vary because I tell people, much like your car, depending on how much you drive it will depend on how quickly it wears out. So it can be a little bit of a concern perhaps when patients are a little bit younger. I do sit down and talk with them, and I tell them if they are in their 40s or early 50s, because they are expected to have a longevity for quite a long time, it is possible they could potentially outlive a knee replacement. With that being said, though, most patients, if they are in their, let's say, 60s, I think a knee replacement with our current technology certainly has the ability to last for that patient's lifetime. So I tell my patients there's no absolute guarantee of how long things can last, just like everything else that we own. But the good news is with today's technology, the implants we see are surviving much longer than they used to 20 years ago. I think part of it too, with the new Rosa technology that we're using, being able to put these in a little more accurately, we feel as though that potentially can give the knee the opportunity to last even longer. We feel alignment is a big component of how knees wear over time. So utilizing that technology, I think, can certainly go a long way at letting people have these knees in for a very long time. It's a great question.
Is a diabetic a candidate for knee replacement?
Absolutely, as long as it's well controlled. Like anything else, surgery is going to go well if medical conditions are well controlled. I have many diabetic patients. It's unfortunately a very common condition that many patients have. What we need to see from an orthopedic surgery side of it, though, is that their diabetes is well under control. We ask our primary care doctors taking care of our patients to make sure that our patients are well controlled with their blood sugar levels. We do have a few cutoff numbers. We do ask that our hemoglobin A1C levels in our diabetic patients are under 7.5. There is literature and studies out there that have indicated over that number there is an increased risk for complications related to the surgery. And I don't think anyone would want to go through a surgery having high risk of complications. And so we look at that very carefully. It is a number that we do have to address occasionally. We have to get patients into their medical provider to help with maybe dietary control to get the number to a more reasonable level. But once it is, and once it's been established, certainly a hip or knee replacement can then be safely performed.
Scott says he has knee pain. Can he expect that will go away with the replacement, or will he still have pain?
Yeah, so if the diagnosis is truly arthritis of the knee, we have to always be careful of that. Knee replacement is very successful at relieving pain. It's why they're done. Since the 1970s, people have been putting in successful knee replacements in patients, and the number one reason for doing it is for pain relief. And over and over, studies have shown the vast majority of people that go through a knee replacement do obtain excellent pain relief. I always tell my patients with pain relief, though, the secondary gain is their function, because by relieving their pain, what we always tend to see is that patients seem like they're able to do more and tolerate more. So that's kind of the secondary gain in addition to the pain relief most patients will obtain.
I do want to give a quick shout out here because Terry and on Facebook and also Colleen on YouTube are singing your praises. So some happy customers, patients there.
It's wonderful to hear that I have an audience out there. That's great. It's always nice to have feedback like that. It's one of the most satisfying things you can do for people is help them out and see them recover well. And when you hear back from them and the things they're doing, that's the satisfying part of being able to do what I do. So that's awesome. I really appreciate the feedback.
Someone said I had knee replacements in 2008, 2010, and 2014. There's no pain or swelling, but lately I've noticed there's clicking during aerobic exercise. What does that mean for them?
Well, number one, it means they're doing pretty well because it's nice to hear that they're exercising. It sounds obviously they don't have three knees. It sounds like they've obviously had two knee replacements and one at some point was revised. Some clicking within a knee replacement is not an unheard of thing. I have patients that have very successful knee replacements. Sometimes with activity, more moderate activity such as exercising, they may get a click or a pop within their knee. The vast majority of people don't report it to be painful. They just kind of notice it. These are artificial components. They're metal and plastic. Some of the more aggressive activities, sometimes those components will click together and cause a little sound. Usually they're not anything we get too worked up about. When I have patients come to the office mentioning it, we'll always take x-rays. We do a great exam on them. We make sure that it's not a sign of anything going wrong. And I got to tell you, in probably 95% of cases, it's not. It's simply just the way the mechanics of the knee replacement are working. Unless it's truly painful or really bothering a patient, most times these clicks or pops within the knee are somewhat normal for knee replacement.
Margaret is asking, how long will I be off work for knee replacement?
Yeah, it's a question, again, I deal with almost every day when talking to patients about this. It's a big concern in patients that are still employed. It kind of depends a little bit on the type of work people do. If you have a person that is doing more administrative work, sitting at a desk, doing some a little bit of ambulation around an office setting, a lot of patients can get back to that perhaps within 3 weeks to a month because they're really not placing very high demands on the knee. Some are getting back to work if you do have a right hip or right knee replaced, does involve driving. So I do tell patients whenever it comes to a right knee or a right hip, it may not be so much the ability to get back to work, but the ability to get to and from work. So they do have to take that into consideration. With a right leg surgery, it's usually a month of no driving. So patients can still go to work, they just may need help with the transportation side of it. Now, if patients have a job where maybe they're doing more standing, they work an 8 or 10-hour shift doing standing, moving around, they potentially may need several months off of work. It is typical to tell patients 3 months is a typical protocol for a patient. Let's say, as an example, if you were a cashier at Walmart, standing, not doing a lot of heavy lifting, but having to stand, move around, most of those patients would require about 3 months off of work. If the work involves a little more strenuous exercise, a little more stooping, bending, carrying, patients can be off work for even up to 4 months. That is not an unusual situation with a little more higher demand type job. Um, One of the other issues we sometimes run into when talking about jobs is there are some patients out there that work very labor intensive jobs. And those can be difficult. We do tell our patients if you work in construction, a roofer, potentially a firefighter, people that really don't have the ability to go back on restrictions, etc. It can be hard sometimes to get back to those jobs after even a successful knee replacement simply because of the high demands that the job can place on the knee. So sometimes I have to have a talk with my patients who work the more high demanding jobs, being sure that they understand that a knee replacement is not always an absolute guarantee of getting back to extremely physical work. I always use the NFL football player example in that if an NFL football player had a knee replacement, there's no team in the league that's going to then hire that person because that job is extremely physical. So sometimes patients need to be made aware of that in not all cases does a knee replacement mean they're going to go back to extremely physical work. But in most instances, 3 months is pretty typical for a lot of patients. And like I said, if their job is a little more sedentary, really it's just about being able to get through therapy, get the knee moving, feel more comfortable with it, and then they can usually get back to an office setting, usually within about 3 to 4 weeks.
And that kind of goes into our next question, which is how long do you have to go to therapy?
Yeah, so again, it varies a little bit. There's no standard answer to that. I will tell my patients that they should expect therapy to be needed probably about 6 to 8 weeks after the surgery. Most patients require that. I may have some superstars that seem to go a little quicker, and sometimes therapy can end slightly sooner. I may even have an occasional patient that requires a more extensive therapy. Some of it does depend on where patients start. I will see sometimes patients that have developed a very stiff knee. They've lost a lot of motion. They don't have a lot of strength. And obviously and understandably, they require more work on the back end after a knee replacement happens. If patients have a pretty good range of motion of their knee starting out, if they have good muscle strength, they may not find that they need as much therapy as perhaps the person sitting next to them after a knee replacement. So there is a little bit of variability on that end, but I usually will tell patients to kind of expect perhaps 6 to 8 weeks of therapy.
Is Rosa safe?
Absolutely. Rosa's very safe. This is a robotic arm. It does not cut anything. I am the guy doing the surgery. It is very simply a robotic arm that helps us place what we would term the jigs used to help align the knee. So it is not doing any type of surgery. There are some versions of robots out there that do this, but I've looked at them and I like this version. This still keeps the instruments in my hand. I think it's more of a measurement tool that we use as opposed to a substitute for the surgeon. My knee replacement when I started using Rosa has not necessarily changed in the pattern that I do it in the operating room. This machine has simply added, I think, another layer of accuracy to what was already a very good surgery. And that's why I've chosen to use it. And I think talking to some other surgeons that I learned it from, they say the same thing about it. And I think a lot of the surgeons out there that are currently using it around the country, we kind of are all on the same page with that. It still allows the surgeon to do their surgery how they want to do the surgery, how the way they were taught, the way they've learned over 20 years to do it. It is simply there to provide an extra layer of accuracy and precision. That's why we've gotten excited about it, because I've really seen that work in the operating room.
We did talk a little bit about how you've been doing this for 20 years, but Janice says she wants to know how many knee replacement surgeries you've done. Do you have a number?
Oh man, I wish I had a total count. And over time you kind of lose track of it. But I can tell you, we do look at our numbers, and certainly this is something we do pay attention to. I know year to year, I do slightly over 200 joint replacements. That's hip and knee combined. That's about my number. That's what it's been for the last few years. I think that's a very reasonable number. There's some studies out there where we actually look at volume and how it relates to outcomes. We do know that surgeons that do over 50 a year tend to have fairly good reproducible outcomes. So there is some science behind that. I tell people, kind of like getting on an airplane, you kind of want an experienced pilot flying your plane. And I think there is some truth to that with these type of surgeries. And so there is a bit, I think, of the experience factor that comes into play. I don't think that's all it is. I try to keep up to date on all the current new technologies out there and new techniques. So I think continuous learning goes a long way in that. But my volume, I think, is very good. That's kind of the numbers I do over year to year, and I think that works very well.
A texting question came in. If you have one hip replacement, how long do you have to wait before you can have the other hip replaced?
Yeah, that's again a great question, and it applies for knees also, because I see so many patients obviously that have two bad knees or two bad hips, or I'll be honest, a bad hip and a bad knee. I will usually space them out if patients really truly want to go through and say, Doc, how long will it take for me to get both of my knees replaced? Number one, I will tell them, we are not currently doing simultaneous knee or hip replacements. We have found that to be a little too risky for patients. It creates risk for complications. And so when patients ask me that, I politely tell them I'm not mean enough to do that to them. I want them to do well and move through it easily. So we will address one knee, we'll let them recover, we'll get them through the therapy program. When they have recovered sufficiently to the point where they're no longer in therapy for that knee, when they're functioning well, then when they pretty much say, Doc, my knee feels pretty good, I'm not really struggling with it anymore, I'm kind of back to doing my activities like I like to do, that's the point where I will then address their other knee. And for many patients, that is about a 3-month interval, because that's about when I see them in my office at 3 months, most patients are doing reasonably well at that stage. They may still have a little recovery to go as far as strengthening and perhaps endurance, but for the majority of people at 3 months, they're back to their activities, they're back to walking around the grocery store, they're back to playing some golf. If they're not having issues with the first side, that's when we'll address the second side. And I've had many patients go through it that way, usually about a 3-month interval, either between hips, between knees, or even between having a hip done and then a knee done, or vice versa.
We have a question coming in. Does knee replacement surgery straighten a leg that has turned inward?
Yes, very much so. And that's one of the reasons we use Rosa. because Rosa is letting us see the alignment of that leg in much more detail than we can see with our human eye. And so, yes, that is a big part of it. It's always been a big part of knee replacement is to give people a straight leg. We don't want to leave them crooked. Knee replacements can wear out too quick if you leave them crooked. It puts too much stress on one side. So a big part of the surgery is to correct people's alignment, to give them a straight leg. Many patients, as their knee wears out, as they start to get arthritic knees, they start to either get bow-legged or the opposite knock-knee deformities. And our surgeries are designed to correct that. And Rosa's actually been helping us with that. It's made that more accurate. Part of getting a straight leg is being able to know where your hip joint is in space. The problem is no one can feel your hip joint. It's too deep in you. And so Rosa, by moving the leg around, it can figure out where the center of your hip rotation is, the center of your ankle. It can determine the center of your knee so that when we put the knee replacement in, you end up with a straight leg. It's pretty cool technology, and that's why we really enjoyed using it.
Is swelling normal after a knee replacement?
Yeah, almost every patient universally is going to have some swelling after the surgery. It can vary patient to patient on the amount and the degree and the time of it. For the first few weeks, yes, the knee is going to be swollen. It's going to be a little bit bruised up. You're going to have a healing incision. Some patients will swell into their calf. They'll swell around the foot. Some patients, if maybe they have a little bit of ankle swelling even before the surgery, it's not an uncommon thing. We can almost expect that they're going to swell even more after the surgery. My patients might use for a couple weeks a compressive stocking on the leg to help with that. And over a course of maybe a month to 2 months, the swelling will slowly start to resolve. Some patients may have a little bit of activity-related swelling for a few months where they'll say after they've been up on it for an hour, 2 hours, walking around the grocery store, for example, by the end of that, they may have a little bit of swelling. That typically resolves by simply elevating the leg for a short period of time, and the swelling will come down. So, but it doesn't typically tend to be a long-term problem for the vast majority of patients. The knee starts to kind of get back to looking like it should.
This is kind of a specific question, so I'm not sure if you can answer it, but I'll ask and then just tell me if you can't. This person said that they had a left hip replacement 4 years ago that left them with nerve damage and a drop foot. They've been scheduled for a knee replacement for both knees, but the surgeon refused to do it because of nerve damage. Do you think it's possible for them to get a knee surgery?
Maybe. I got to be honest with you. Anytime we do a presentation like this and there's a very specific question related to a unique situation, my general answer is I probably can't really answer that accurately until I examine or see the patient and really see what's truly going on. It doesn't sound unreasonable given the information you provided me. I think a knee replacement could still be considered. A knee replacement won't fix the drop foot, unfortunately. That's an unfortunate complication and a fairly rare complication after a hip replacement. I've had some patients in the past who have had it for maybe other reasons even. A drop foot is not unique. There can be other conditions where it does happen. These patients can still be candidates to replace their knee, though. But again, the individual person, I think in that situation, before just making a blunt statement, I would probably say best to probably have that individually analyzed. That's a patient I would love to see in my office to take a look at both their hip, their knee, x-ray, physical exam, really see what's going on so that we could probably come up with a concrete solution for that patient. But I definitely wouldn't say, based on the information you provided me, that it's an absolute no. That's for sure.
Nita says, what are your parameters for deciding to do surgery on someone over 85 with atrial fibrillation and deformity of the knee?
That is a little bit of a tricky one. Certainly age of it and of itself does not preclude us from surgery. I actually just did a knee replacement in a nice lady. She was 92 years old, but she was a healthy 92 years old. Good for her. That age itself does not really play a big role in whether or not surgery. There's some studies out there that perhaps show a very, very slight increase in risk over the age of 80, but that risk is relatively small. And so we don't really think age to be a big player when patients decide to either have hip or knee replacement. What really it amounts to is medical conditions. Unfortunately, if patients do have a large amount of medical issues, this can sometimes preclude them from knee replacement. Patients with heart conditions, anybody, I don't care age, what age they are, if they're going to have surgery, they always need to see the cardiologist beforehand. I hate to say this, but regardless of how much their knee or hip hurts, I can't do surgery if the cardiologist says they can't have surgery. So we do rely on that. And anyone that has a history of atrial fibrillation, that's not an unusual condition. Lots of people out there have that. We are doing hip and knee replacements on those patients. It's just they would need to be what we call cleared by their cardiologist before surgery would happen. So certainly could be an option.
Dr. Telehowski, I know you've answered a lot of questions here. There are still a couple more. Are you up for a couple more? Or?
I'm happy to.
Okay. Andrea is asking, are cortisone shots okay with osteoporosis in the knee?
We do them. Yes, I think they are okay. The concern on that end is frequency. I think if patients are only getting perhaps 2 to 3 a year for their arthritic knee, they're probably within a safe zone. Beyond that, we don't recommend usually doing them too frequently, too often. But it is a way in the office we can help control their symptoms. And so, doing them periodically is not, I don't think, a big issue. Osteoporosis, I don't think is going to be affected by a one-time cortisone shot to help control arthritis type pain. I think in those instances, you worry more about patients that are taking oral steroids daily. I think that plays more of a role. But the occasional, maybe twice a year injection into an arthritic joint, even in the face of some osteoporosis, I think is still an okay thing for patients.
Colleen says it's been 2 years since knee replacement and I'm still getting a little swelling. Is that normal?
Yeah, it can be. It can be. Sometimes, certainly with activity and such, some patients might have a little bit of that. I think we have to sometimes take a little bit of this with a grain of salt. Most patients who have a successful knee replacement, I think no matter what you ask them, can always find something to mention about it. But in the end, usually these patients, when you really say, yeah, but do you want your old knee back? They'll usually say, not at all, not at all. They'll take a little bit of that swelling as a trade-off for what is usually very good pain relief. So it's just like the clicking issue that was talked about earlier. I think sometimes you have to take a little bit of that. We don't deny this is an artificial knee. It's not, some miracle thing. It is metal and plastic that's going in. It provides good pain relief, but there can still be small things that patients may notice even after a very successful knee replacement. But in most instances, patients can accept that because what the trade-off was very good pain relief.
Okay, it looks like that's it. Thank you so much for answering all those questions. And it was quite a bit, but really good answers and good stuff.
No, that was great. Those were all awesome questions. These are questions that I answer every day in my office. This is kind of the stuff that almost every patient who's interested in this type of stuff comes in and asks me about. And I love to sit down with my patients and talk about it. It's one of the things, if anyone's ever come to my office, I think that's what they mention about me is that I like to go through this stuff. I like to sit down with patients and make sure that they are well informed, that they understand what this is about, so that in the end, they make, number one, a good decision for themselves, and number two, they understand how I'm trying to help them. And I think just conveying the information and educating people about these conditions and what we have for them, it's a wonderful thing. And I tell you, it's so satisfying to see patients come back a little bit down the road after these are done. They got a big smile on their face. They're back to playing golf. They're back to going out hiking. They're back to going on vacation with their spouse. They're doing all the things that they couldn't do 3 months before when I first saw them in my office. So I encourage people, if they have questions, to call, make an appointment, come in and see me. I'm happy to sit down with them, talk to them about their options of how we can help them. It's not always about surgery. There's things in my office that we do for a lot of patients. It never comes down to surgery for them. It doesn't have to be a surgical visit. We're just here to help people out with their joint pain.
Okay, thanks everyone for joining us. And remember, you don't have to live your life with pain. You can be pain-free. Hope you live a healthy life, and thanks a lot for joining us. Have a great day.